My name's Lauren Hoffman. I'm from Albert Einstein College of Medicine or Montefiore Medical Center in the Bronx. And the title of my talk today is the anti-inflammatory benefit of Levofloxacin-Metronidazole-Rifampicin in the treatment of HS. And I'm not going to lie, I was a little nervous to give this talk beforehand, but today, with the spirit of the debate, I'm really excited to put my gloves on and get in there. So hopefully you guys can contribute to what I have to say here. So we'll get started. I have no disclosures, and there are some disclosures from the authors who contributed to the presentation. However, the data that we looked at did come from an AbbVie-sponsored protocol looking at the longitudinal quality of life on HS patients. So here's a brief outline. We've kind of talked at length today about the history of antibiotics and the use of HS, but I'll just review those with you. Then I'll go into what we did for our study, our results, and try and put them into context. So I think it was made clear today, if we're going to use antibiotics, we should be asking ourselves, why are we using antibiotics? Or another way of asking this is, do bacteria play a role in HS? And I think as providers, we can all agree that HS rarely presents as a cellulitis. It rarely presents as an infectious process. And this was presented earlier today in great detail, the meta-analysis by Ring and his group, that most of the time we have negative culture reports, or the other 50% most common organisms identified were Staph aureus, coagulase negative, staph, and anaerobes. So coming from the European S1 guidelines, they recommend 3 main groups of antibiotics to be used in the treatment of HS. We see the tetracyclines, which are historically used for follicular diseases. We also see clindamycin and rifampicin. And I think an added benefit of these medications are that they synergistically work to decrease the other side effects. And then finally, we have the rifampicin, moxifloxacin, and metronidazole combination, and we were lucky enough to hear from Dr. Nassif today in great detail about her study and the study that her group performed using these antibiotics. So my plan was to go over this, but as I said, she did such a great job, and we really were lucky to have her talk about it herself. So I'll just remind you the basic idea was a retrospective study looking at patients who took the triple antibiotic regimen for 6 weeks, followed by just rifampicin and moxifloxacin for another 6 weeks. And what I took away from it was that majority of the patients in all of the patients in stage 1 and almost all of the patients in stage 2 met their criteria for complete remission. So we're seeing this trend of this combination working very well for early stage disease. So I'll say that in our treatment center, when we weren't seeing the results that we liked with clindamycin and rifampicin, we were very inspired by this study, and we started giving patients this triple antibiotic combination. And a few months later, we tried to analyze that data to see what the effects were. So we conducted a retrospective chart review at our treatment center in the Bronx. Patients in our chart review or in our cohort had to have been on the triple antibiotic therapy in these dosages, and they must have completed both a baseline and 6-month quality of life questionnaires that were part of a larger longitudinal study. So we were interested in looking at clinical outcomes, which were patient-reported tenderness, % drainage of existing lesions, and the number of HS flares. We also looked at quality of life measures, such as the Dermatology or Quality of Life Index, DLQI, and the Quality of Life Enjoyment and Satisfaction Questionnaire. And we were interested in looking at differences in median scores between baseline and 6 months and the percentage of change, or the percentage of patients who had improved scores. And we did this with descriptive statistics and the Wilcoxon signed rank test. So I'll briefly go over our demographics. We had 19 patients in our cohort, 6 male and 13 female, which is pretty characteristic of the 1 to 2 ratio. And 15 of our patients were in early stage 3. So we had a little bit more on the more severe side, which I guess is to be expected in a tertiary care center. The last thing I'd like to point out that our patients were on this antibiotic combination for a median time of 7.5 months with a range between 4 to 12 months. Not noted here, most of the patients in our cohort had disease in their axilla, the inguinal regions, and in their buttocks, or the buttock area, and we noted that a few of our patients were on additional medication at the time that we collected their information. So these included the chlorhexidine wash and clindamycin gel, the spironolactone, and biologics such as infliximab and adalimumab. So let's jump into our data, and I'll try and orient you here just a bit. So we have plotted the individual scores for the patient clinical outcomes at both baseline and 6 months. The black lines represent the median scores of each of these measures. And then I wanted to point out that tenderness and drainage kind of look like this because these were patient-reported measures in which they had a limited number of responses. So for example, they could report tenderness as 0, no tenderness at all, with a range of 3 being most tender, having the most tenderness. So we found that, went a little bit ahead, that's okay. We found that there was no reduction in tenderness scores at 6 months. There was a reduction in percentage of drainage at 6 months, but this was not significant. And however, the number of HS flares was significantly reduced at 6 months, and this was a measure that patients could self-report. It was they could write in the number of flares. And one thing that I thought that was a little complicated to see in these graphs is you couldn't get an idea of how an individual improved over time. So we calculated the descriptive statistics, and we found that 8 out of 19, or 42%, had reduced tenderness, 9 out of 19, or 47%, had reduced drainage, and 17 out of 19, 89%, had reduced flares. We looked at the quality of life measures very similarly. So you can see here that patients had a significantly lower DLQI at 6 months, and a lower DLQI is representative of improved quality of life. The other quality of life measure we looked at, the opposite is true, so a higher score actually represents an improved quality of life measure. This was improved at 6 months compared to baseline, but it was not found to be significant. And again, we included the descriptive statistics for these, or the percentage of patients who improved. Another part of our protocol in the treatment center is to get bacterial cultures of lesions from patients who we want to start on antibiotics if they're draining. So we found that in our cohort, 13 out of our 19 patients had reported cultures. 8 out of those cultures were polymicrobial, and the most common isolates were normal skin flora, or what our lab determines to be normal skin flora, and beta strep group B. So not much different from what was found previously. So in summary, we did find that HS flares and quality of life improved with the long-term use of triple antibiotics, but we were kind of left wondering, why are patients improving if they have normal skin flora? Or rather, the mechanism of why these antibiotics are working is unclear. So I think that most of us are familiar with the antimicrobial aspects of these antibiotics. However, I tried to look in the literature to see, and I indeed found that these antibiotics also have some inflammatory properties, a lot which are listed here, but to name a few, they can inhibit IL-8 TNF-alpha production, inhibit NF-kappa beta translocation, they can modify cell-mediated hypersensitivity and antigen-induced transformation of lymphocytes and T-cell function, and in general, they have many ways in which they can suppress cellular immunity. So, to wrap up, I think I have just a few points to consider which have been mentioned today, but when you're prescribing antibiotics, especially at this complicated scheduling for patients, you have to consider that these antibiotics don't come without side effects, and because we're prescribing at such a difficult schedule, patients often will report to us that, I forgot a dose, it's very complicated. So we try and combat that by giving them a clear calendar of when they should take their medicines and what they should be taking, but it's difficult, and I can empathize with that. We have discussed at length today the bacterial resistance, or is this a real thing, which I think it is, but how do we consider that in the antibiotics that we treat in patients with how do we how do we contribute that when we treat patients with HS with antibiotics? And finally, I think just tying up a lot of the points that were made today, especially when I have my other hat on and I'm looking at the serum biomarkers, are there other systemic treatments we should consider, such as hormonal or anti-hormonal treatments or some of the biologics that can cut down on inflammation? So that brings me to my conclusion, and I want to thank Dr. Cohen and Yesra from Albert Einstein, who were very instrumental in collecting the data and helping me analyze it, and also the SHSA for giving me the opportunity to present. Thanks.